every horse at this point has been exposed to it and has it. So an animal that has become infected with it will carry it for life, and it can go through phases where it starts shedding again. Once you start that reshedding cycle, you can either have, reinfection of the host, or you can obviously spread to other horses.
What if I told you that your horse carries a virus right now, and that almost every other horse at your barn, at the show, on the trailer, carries it too? Most of the time, nothing happens until it does. Last year, EHV1 moved through the Western competition circuit, and horses went down, literally, suffering neurological symptoms in a way most of us had never seen before. It made the news. It sparked debates about whether NFR and other horse competition events should even happen at all. And then it got quiet, which is exactly when we should be paying attention. My guest today is Dr. Bruno Karam, an equine internal medicine specialist. This conversation is about what you need to understand before the next outbreak, not after. In this episode, we tackle what EHV1 is and why almost every horse already carries it, the difference between EHV1 and EHM, what vaccines protect against and what they don't, and why temperature monitoring is your first line of defense. Let's dive in.
Welcome to the Noelle Floyd Podcast. It's Dr. Bruno Karam.
Before we begin today's episode, I'd love to ask for your support. The simplest way to support this podcast is to hit follow or subscribe wherever you are listening. It helps the show reach more people who care about the same things that we do. Better horsemanship, deeper conversations, and a more thoughtful future for horses and the people who love them. And if this podcast has meant something to you, leaving a rating, a review, or a comment makes a huge difference. So thank you for being here. I really do not take your time or attention for granted. Now, let's dive into today's episode. All right, Bruno, welcome to the podcast.
Thank you for having me.
Okay, I'm super excited about this episode. This episode is going to knock the socks off of a lot of our listeners because we're going to dive into essentially the concept of viruses and what we're now navigating as modern horse owners, as modern horse people. Now in the world of pandemics, the horse world is not immune or exempt of pandemics, right? And that's something that you've seen in your work. Why don't you share a little bit with everyone what it is that you do?
Yeah. So I'm an internal medicine specialist, and basically internists, we deal with more organ systems, if you will. And within that, we also obviously deal with infectious diseases, which is what we'll be talking about. A little bit different from, the human side and even the small animal side. With horses, we don't have as much of a kind of a subdivision of your specialties, right? We don't necessarily have a strictly equine cardiology, neurology, some of the just the respiratory disease or endocrinology or dermatology. In small animals, you have all that. These are all in the United States under the same college, if you will, of internal medicine, but they're each a different specialty. For equine, likely due to the demand and the sheer numbers out there, there's not enough to sustain that. So we don't have an internist end up doing all of it. So the GI stuff, the respiratory, oncology, cardiology, we do them all. Now, obviously, there are some that go on to have multiple specialties, but for the majority of us, that's what we do. So it's a little bit more unique in that sense because we do end up having to know a lot as far as getting through a residency, if you will.
So I've had a number of vets tell me about your work and speak very highly of you. You have worked on some really unique cases. Why don't you share a little bit with our listeners what type of cases that you've worked on that are really strange or ones that we might not expect?
I think you always have to be ready to see something unique and different, right? I would say zebras are uncommon in our world, but they do pop up. And not that we should always be focused on them, but you should be ready to see them. And even in our profession, we do get sometimes, humbled by these unexpected cases, because you feel like you see a pattern so many times that you learn to recognize it, and you kind of get tunnel vision towards this pattern recognition more so than relying on your clinical skills and your overall assessment. um, I really enjoy critical care. My favorite type of cases are emergency. I like things that are, not in the good state as they come in, and that can certainly be challenging because you're not going to win all of them. So you got to be ready for the ups and downs, and you go through phases where you feel like you can do no wrong, everything you touch lives, and then you have phases that you can do no right, that everything you touch ends up with a negative outcome. But we had a few cases. I think as far as unique cases, I do like a case that we ended up publishing as a case report, um, about this miniature horse with yellow fat disease. And what I actually liked about that case was especially that was the fact that, interestingly enough, um, the the diagnosis was actually recognized by a technician who had seen it in a dog. And it's not like it's completely unheard of. It's very uncommon if you in horses especially. But, it was exactly that. She brought up the question, could this be? And, we pursued it, and sure enough, that's what it was. And that was really cool because that just shows kind of how, everybody in the team can play a role in the successful outcome of our patients. So that's definitely interesting, and it kind of gives you a perspective of, kind of being an all-inclusive where you don't punt someone else's role to just a specific thing, but actually take into consideration what they have to say. And then, I think when you're your own worst critic, I think there's also, you tend to stick with the bad cases, unfortunately, which is kind of sad to say, but it is a reality. And I certainly have cases where, you know, horses that did not have a positive outcome, but I developed a huge appreciation for owners' commitment and the resilience of those animals. And I can think of one specifically where, it's even a little bit emotional to talk about it, but it was a case where we tried really hard, and I think that horse probably made it for longer than we would have expected a horse to do under those circumstances. He had really bad aspiration pneumonia, so he had a what we call a choke, which you might have heard of, but he was aspirating a lot of fluid during that process, and he developed really bad secondary pneumonia from that. It was really critical, and that owner didn't quit on that horse. That horse meant everything to her. And the horse was tough enough to warrant keep trying, but to get to that point that you realize that that animal has had enough, that um, you can do no more right for that animal short of you know humanely putting it to sleep. That's very difficult, and it kind of stays with you, where you have to have that conversation. Never want to tell the owner that that's what needs to happen. You want to let them reach that conclusion of their own and respect their bond with their horse. But that was a hard case, because I don't recall many times that I feel like I'm good enough with what I do in these tough conversations that I can lead the owner into the decision. But this was one that unfortunately I had to tell the owner, because you could tell that horse could go no longer. So it's not all flowers, but I think in the end of the day, you feel like you're doing the best you can for that animal, and there's acts of kindness in all directions, right?
Absolutely.
So
Absolutely.
yeah.
It's interesting you mentioned diagnosis bias or pattern recognition versus maybe leaning on your clinical skills, because I'm interested before we dive into EHV1. I'm actually interested because I saw that and observed this tendency within the veterinary community around EPM.
Yeah.
Do you find that to be true?
I think it's true for a lot of things. One of the struggles that we have with, as we become better at providing new diagnostics, if you will, is making sure that we understand the limitations of the diagnostic, right? Like a result has to be interpreted in the face of its limitations and the clinical presentation of your patient, and not just the result for what it is. And that's applicable to even, EHV. The other thing is that as things become more easily accessible, there's this tendency of drifting towards, even in vet school, where we're training students to be diagnosticians more than clinicians. And what I mean by that is that, it's kind of like catching fish. You cast a net that's big enough, you're going to catch something, but that doesn't mean that you're learning the basics of how to do it. So I think the most basic fundamental of being a veterinarian is that clinical skill, right? To do your physical exam and understand what's going on with the patient and pick up what's abnormal before you even delve into your actual diagnostic results. And that's why, in my opinion at least, I would put livestock veterinarians as the top, especially the experience that I had with people in academia. I've always admired them a lot because these are generally animals that people are not going to spend a lot of money on, right? Because they're seen as a product, so to speak. So they're more cautious with how the money's spent. That animal has a value. So a lot of what you do has to be based on your knowledge, your clinical knowledge. So they have overall a better grasp on the clinical assessment, the history taking, everything, so that they can focus on what's absolutely critical for diagnosis and treatment of their patients versus having the ability of, I'm at a university, I have all these labs at my disposal.
Right.
They're usually subsidized. Let's just do it. And then forego your clinical skills, what's really important when you get out in the real world, because otherwise you just start running tests and saying, this is what the horse has, and you might be wrong, and sometimes it will be, right? And that's true for anything, including whether it's EPM, whether it's metabolic syndrome is another big one, that we just running insulin nonstop without thinking about what does that mean, right? It's not a static parameter, it's just one time point, and treating patients based on that as opposed to following up with a proper diagnosis.
So insightful. Okay, now let's dive into horse COVID, as people were calling it. So, we're 2026, last year, in and around the National Finals Rodeo, around a series of big Western competitions in the United States and in the southern part of the United States, specifically around Texas, there was a huge, what would you call, it was this huge surge of EHV1 cases that were presenting neurologically, not respiratory, right? Before we dive into the nuances of that situation or those events, I would love for you to explain what EHV1 is to our listeners, for those who are listening who maybe are not as familiar with this. What it is, how it presents, and why every single horse owner or every single person in the horse industry needs to know about it.
Yeah, so when we talk about EHV, especially in those circumstances of having, what you describing as multiple horses getting an outbreak, right? That's what it is. You have a surge of cases from a contagious pathogen that goes around, and then you have a bunch of individuals that are sick and or positive and spreading it for a period of time. That's what we describe as an outbreak. And we are specifically talking about equine herpesvirus 1, or what we refer to as EHV1. Within equine herpesvirus, there's different families of equine herpesvirus. So there's EHV, 2, 5, 3. There's EHV4 that's more closely related to EHV1. But the one that we tend to focus on these instances are EHV1. And EHV1 is largely considered a respiratory virus.
I want to take a quick pause to invite you into my brand new Substack. Each week, I publish essays on the horse world, from equine industry insights, horse culture, equine economics, even the more mystical, spiritual, and relational side of life with horses. It's where I write more candidly about what I'm seeing, questioning, learning, and working through with my own horses. A lot of these essays are inspired by the wisdom of my podcast guests, my NF Plus instructors, and the incredible horses who keep asking me to look deeper. There are free and paid pieces, and subscribing is a beautiful way for you to support my work in the horse world. You can find my Substack at noellefloyd.substack.com or through the link in the show notes. Now, let's get back to the episode.
EHV1 is largely considered a respiratory virus. Okay, so it causes respiratory disease. The thing that's unique about it is the fact that it's A, highly contagious, B, every horse at this point has been exposed to it and has it, and C, the fact that you have what we consider recrudescence. So an animal that has become infected with it will carry it for life, and it can go through phases where it starts shedding again. And those can be triggered by a variety of things, including stress. And that once you start that reshedding cycle, you can either have, reinfection of the host, or you can obviously spread to other horses. So that's kind of it for EHV1 as far as we're concerned from the outbreak perspective. Beyond that, EHV1 can also cause what we consider abortion. So it can go through to the uterine tissue of a pregnant mare and lead to abortion, or it can cause some very sick neonatal foals that can possibly die from it. It's very serious for them. They get pneumonia, and they can have a high incidence of neonatal death from it as well. But majority of it is respiratory disease. The horse will acquire at a very young age, likely from the mare when they're babies. And, most of them will have a very mild respiratory disease from it. There can certainly be complications. And the biggest complication would be what we saw, which is what we call equine herpes myeloencephalopathy, which is EHM, being that EHM is the neurological disease. So it's not a virus.
Okay.
It's a neurological disease caused by the virus EHV1.
Okay, that's an important distinction. Mm-hmm. So it's like a byproduct of having or presenting with EHV.
Yeah.
Okay.
Yeah.
So you said something that kind of blew my mind, which is that all horses have been exposed and almost all horses have EHV. So does that mean, and I've done a bit of reading around sort of the concept of the herpes virus and how it presents across, not just in horses, but in people. So there's an element to the herpes virus where it remains dormant within the spinal fluid. Is that correct?
So for the horse, it's going to be in like lymphoid tissue or the trigeminal ganglia. So it's not going to be in the spinal fluid of the horse.
Wow.
If it reaches that level, then your concern would be kind of actually getting seated in the microvasculature, so the tiny vessels that feed into the spinal cord, and not so much the spinal fluid. You can certainly detect it on the spinal fluid of the horse, but at that point it might be a little bit trivial as well, because you would be detecting it elsewhere possibly, or you'd be addressing the horse clinically.
So if most horses have been exposed and most horses have EHV, and then why do some become neurologic and some do not?
Yeah, so as far as how they each present, I think that's kind of the whole basis of what we also see with humans, right? It's the notion of when you're talking about a viral infection or many infections, as a matter of fact, there are two factors to it. One is the virus itself, right, the pathogen. The other is the host and the host's ability to fight it. So I guess the analogy is you and I could be standing next to someone sick at a bus stop, that I may get sick from it and you may not. And we might be the same distance from that person, being exposed to the same amount of virus or whatever it may be, that my body doesn't handle it the same way that yours does. And the same is true for our animal species. And that can happen in the face of an animal being vaccinated or not. Right. And when we talk about vaccines for equine herpes virus, those vaccines, if we're going to focus just on the respiratory disease, it is protective for the respiratory disease. It's not protective for the neurological form of the disease. And no vaccine is 100%, but the beauty of it is that in a perfect world, what happens is that, that animal will have more mild clinical presentation, and B, will be shedding less. So that's more of a herd immunity perspective, where it won't be as contagious for other animals surrounding it.
Okay, let's talk about the concept of shedding. I think it's important for us to explain what that is and how it pertains to viruses like EHV.
Mm-hmm.
So what is shedding? Like, what does that, and why does it happen sometimes and not, it's something that happens sporadically and not necessarily within a pattern, correct?
Mm-hmm. Yeah, so shedding is just basically that, again, when it comes to HV1, it's the animal releasing, if you will, the virus through its nasal secretions. And that's how a respiratory virus or a respiratory disease gets propagated, right? For example, coronavirus in horses gets passed on through manure versus respiratory for the most part. That's how it's contagious. So the shedding pattern is however mechanism the virus has to be released into the environment and then go on and infect a different host. And you're right, because you have that dormant aspect to it, you can have, again, recrudescence where an animal may shed and it may be subclinical. You may never know that that animal is shedding and it's perfectly healthy, but it's shedding some viral particles. Now, at what point are those particles enough to make another horse sick or not? That will vary based on the specific instance that or stress that that horse may be under. But it does happen a lot more frequently than we probably would like to think.
Right.
And that is the whole reason why we don't actually necessarily go around testing every horse, because you will find healthy animals that are shedding, and that is just part of the cycle. And there's not going to be a strong relevance to that. Otherwise, you're going to be isolating and quarantining a lot of horses. And most of these horses that are shedding quietly, they're not necessarily making everyone else sick either.
Interesting.
So again, you do have to discriminate a little bit when you're testing because of that, because you have to be able to interpret the relevance of that host to the entire herd health.
So let's talk about vaccines. Vaccines are now much more prevalent than they were 15, 20 years ago. Why is that? And how effective, what is the true efficacy of vaccines nowadays for horses, for, let's say, EHV? Because it's for respiratory, not for neurological.
Yeah, and I think that's kind of a big topic for a lot of people, because that notion of when people hear, well, it's not protective for the neurological disease, it often raises questions about what shouldn't be done, right? Should we even be doing it? We know, as far as from the respiratory standpoint, for a horse that's going to have a high risk of exposure, so maybe a horse that goes to a lot of shows throughout the year, the recommendations would be to do it every 6 months. And I think even more recently with this last outbreak, we're looking more and more into, discriminating for antibodies that can give us a clue at the risk of the individual, right? Is that individual at a higher risk and arguably needs to be vaccinated more frequently than others by looking at serology, so taking a blood sample and looking at concentration-specific antibodies for that individual horse. I think the challenge with that is that we still don't know what the normal variation would be, or at least I haven't seen anything recently on that aspect. So, it's having to grasp of how do we then translate to owners as far as the necessity of doing these tests, right? Or how often are we going to do? So you can certainly have, if you have a concern of a horse being compromised or whatever it may be, do you have to adjust the vaccine schedule? Possibly. But I think we've also understanding that no vaccine is perfect. But again, it's going back to that notion of, A, we are protecting our own horse from possibly having a more mild form of the disease, right? Or the diseases that can be protected by it. And B, we're shedding less and being less of a harm to other horses surrounding it. And not all pathogens are going to be the same. And there's a lot of things that we don't see commonly, but we vaccinate because if the horse were to get it, it would be catastrophic.
Right.
Right. So, I mean, you can argue that for maybe rabies is not the perfect example, but, when you look at your combo vaccines, your Eastern, Western, Venezuela, like these are things that, many people, if not most of us, will go our entire career without ever seeing the case. But if an animal were to get it, that has some severe consequences, or even tetanus. I mean, tetanus is one that would probably good to mention, because that's one that, it's fairly harmless for the benefits that you can get should a horse get tetanus.
Okay. Actually, something that I didn't think about asking you, but I really want to ask you, which is during the COVID pandemic for humans, we saw a debate that I don't remember ever having seen before, at least not in my lifetime, which was a debate about whether to get vaccinated or not. And then since that pandemic, I've actually had more conversations within people within the horse world who are actually anti-vaccine about horses in general, which I was fascinated by. Because there's a lot of emotion around vaccinations in some subgroups within the horse world, just like there are some subgroups within the larger human community that there's a lot of emotion and belief systems around vaccines. What risks do we know of when it comes to vaccinating our horses, or maybe specifically vaccinating our horses for EHV1 or EHV?
Yeah, I think any horse, to me, the way I look at vaccines and I try to convey to owners is that it's a risk assessment, right?
This episode is brought to you by Pegasus Equine Training and Rehab. And I'll be honest, guys, this one means a lot to me personally. Since coming back to the Pacific Northwest, Pegasus has become such an important part of my horse's care. Founded by Dr. DeDomenico and managed by Melissa Ledford and her team, Pegasus is a truly world-class facility in beautiful Redmond, Washington. Their aquatics program has been incredible for building strength, supporting weight management, and helping ponies like Ginger and Bella come back into optimal health. Honestly, after a fresh clip and months in the pool, these ponies look like completely different horses. My mare Lady has enjoyed shockwave therapy, all-day turnout, and her and I have had a blast on the world-class track that sits at the heart of Pegasus' 120-acre facility. Pegasus also offers resources like hyperbaric therapy, radiographs, dental care, vaccines, bone scans, and ongoing rehab and performance support. Their team have been handpicked to oversee some of the most eye-opening rehab cases I have ever come across in the horse world. But what makes Pegasus so special is the people. They've supported each of my horses as individuals, and they have made me feel like part of a real horse-first community. Check them out and learn more at PegasusTrainingCenter.com.
To me, the way I look at vaccines and I try to convey to owners is that it's a risk assessment, right? It's what is the risk of your horse being exposed to it and getting sick from it. And that's the conversation. I mean, nothing that we do as far as a medical treatment for a patient, everything has its pros and cons, and you have to weigh the both and see, okay, are we doing more benefit or more harm, right? So every time you vaccinate a horse, there's a risk for a vaccine reaction, and they can react to a lot of different things in the vaccine. And yeah, I mean, if you go down to the worst case scenarios, there are some reactions that have been fatal, and yes, they are documented. I think also with the, with social media becoming more prevalent, you tend to have a lot more exposure to these extreme cases, right?
Yes.
For both the good and the bad. It's like when you go on social media and you see about, twin horses there thriving. Is that the norm? No, or at least not without some complications at first. But then you see those stories and you tend to be like, oh, maybe twins are not such a bad thing. Similar with vaccines, you have these horror stories of horses, croaking at the point of the needle, and you're just like, oh my God, the vaccine killed the horse. And it's like, do we have all that data that it was truly the vaccine? And yes, if you have an event and then have an effect, then you can try to correlate the two. I'm not saying it's impossible, but we also have to keep in mind, it's like, how often does that happen? Right. And
what is the true statistic?
And as veterinarians, we take that into consideration. It's not that we downplaying the risk of reactions, but we also, have to base our recommendations on what we believe it's going to be the best for that patient as far as a risk. So if your horse is out in a pasture and it's, 30 some years old, and do you really want to go through the hassle of doing most of these? The answer might be no. Right. But to me, that's a conversation. You just say, there's a small risk, there's a risk. If we're all comfortable with it, life goes on and you don't do it. Or obviously if there's a horse that has a known reaction to a product, then you say, find other alternatives to try to prevent it. That might not be that vaccine. But generally speaking, I think you'd be asking the wrong crowd to say that, vaccines are not a necessity in our industry.
Totally.
And again, it comes down to not necessarily eradicating something, but being protective to the individual and others.
Mitigating it, mitigating the risk of it.
Yeah.
So, okay, let's look at last year. So you ended up on the news. A lot of vets ended up speaking to not only equine media, but mainstream media about this huge outbreak that was the way that it was being communicated, in my opinion, was it was very scary, right? There were really famous horses ending up in hospital, ending up needing to be put down. Like, it was a very scary moment. This happened at the end of last year ahead of NFR in Las Vegas. There was a lot of controversy about whether NFR was going to happen. And then it kind of died down. And then now it's like as if it didn't, it's not like as if it didn't happen. But it kind of feels like as if it didn't happen. Kind of like our pandemic, right? COVID. It's almost as if it didn't happen. So let's kind of I want to dissect this with you, because I'd never seen or heard of the neurological strain. Is this the first time it ever kind of reached pandemic levels?
No, we've seen it before. And the one thing to keep in mind is that every outbreak that we see is different. There are different circumstances. They may be different geographical location, different demographic of horses, whether it's breed, age group, what they do for a living, where they're coming from. So every outbreak is going to be its own little pocket. And in part, that's what makes it so hard to be ahead of it, because we always retroactively looking at it and looking at what worked and what didn't work. And again, not every conclusion that's made from one outbreak is going to be able to be applicable universally to every outbreak and or show that you face. So you have to be able to interpret the data that's there with a grain of salt and see what can be translated or not, right? And I think that's the first part. These outbreaks with EHM have happened before, and they typically, or at least as far as making it the news, they happen at shows. And it's the very good reason for that is because it's kind of like epidemiologically speaking, it's a perfect storm,
right?
Because it's a small confined area with a high density of horses. So you're getting horses from all over the place, and you hauling them hours, if not days, and then you put them all with different horses that you don't know what their immune status is. You don't know, where they came from, whether or not they're vaccinated, what co-current disease they may have. You're throwing them all in together.
They're inherently more stressed.
They're inherently more stressed. The immune system is down. And it just really is a perfect storm, especially for something respiratory that's so easy to contract or it's so contagious, right? And you have a lot of people coming in and out, and we tend to neglect that, which is the human, right? Touching one horse and then touching the next. That's probably one of the biggest ways that we can spread the disease, because how is a horse that's, 15 stalls down in a different barn getting something from a horse that, it's so far away? Well, it's us. It's not the birds, as we like to think sometimes. So, these all play a role in these outbreaks and how they get spread. And in this particular one last year, and admittedly, or thankfully, I guess in that sense, I was not in Texas, so I was not in the heat of it.
Yeah.
But having worked in Texas, I know a lot of people in Texas, and yeah, it was a big deal. It was not to be downplayed, because what we had there that I would say was a little bit unique was more the potential. When you look at the previous ones, or if you want to pick some big ones, they would usually be Southern California at specific times of the year. That's a more consolidated as far as travel. These horses came from the outside, but they spend a lot of time there. They don't just hit there for 2 days and then bounce back and go somewhere else.
Yeah.
This particular one last year, the big issue with it was just the potential. It could have been
because the nature of the way Western shows work. So they're shorter, but it's more of a circuit.
Yeah.
Versus a destination event.
Yeah, you're traveling everywhere. So you might be for 3 days at one venue, and then you go and you travel.
Yes.
So that it's going to increase the number of what we call, not primary exposures, because primary would be the first horse that's sick, not touching noses, but, infecting another horse.
Yeah.
But that other horse that's been exposed now going elsewhere. So you end up getting secondary and tertiary exposures, and that exponentially is going to increase the number of exposed horses that could potentially come up sick. And that it's also going to prolong the time frame of an outbreak. So it's not uncommon for us to see two waves where, at first it's mostly the primary exposure, but then now you're seeing horses that have secondary and tertiary exposures spike up again, the number of positives because of that. And these shows tend to be sometimes even shorter than the actual incubation period of the virus. So incubation period is the time that an animal will acquire a pathogen to then being sick.
Presenting physically.
Physically with clinical signs, so you don't pick it up. And by the time you pick it up, that horse might be in a different state or a different, venue. So that was, I think, as far as, what made it more unique in the recent years was just the potential to be a lot bigger than what it was. And I think we also have to give credit to those that were heavily involved, even from the veterinarian community, to be outspoken about we need to put a stop to this. We need to halt travel. We need to cancel shows, because it's not easy to do that. It's a big task to ask a veterinarian to stick their neck out and say, you can't resume with your livelihood, right? Because it's not just, the main thing is the health of the horse, but you're also talking about people's livelihoods, people that rely on transportation, on riding horses, on cleaning stalls at these, there's so many people.
Well, and as well, the investment. I was involved in lots of conversation, which the opinion of many was that the NFR would go on regardless because the sheer amount of money invested in that event would be considered primary over the life or the potential risks to horse life.
Yeah.
And that was the first time I'd ever been part of conversations in which I realized that economic investment
it's a huge part of it too.
And we know that NFR did resume.
Yeah.
I think was there any cases of EHV that derived from that event?
I don't recall seeing anything big coming out of the NFR. It's also really hard to track the true number of positives for a variety of reasons. One would be that when the virus has that neurological presentation, it's still being acquired and transmitted to the same pattern of EHV1, because again, it is EHV1. So it's still nasal secretion and another horse coming in contact with those aerosolized droplets or a bucket or whatever it may be. So in that sense, I think it's, how many horses probably got it or carrying it, but were not sick from it. That's definitely something that we don't have the numbers for. And I think partially that's where a lot of the commitment from a lot of veterinarians that were directly affected by it, did really good. There was a lot of veterinarians that were really pushing to try to track those horses and collect samples, right? Because the horses that are exposed and don't get sick, sometimes for knowledge or research base, are just as important as the horses that did get sick, because then we can try to figure out, okay, why? What is the difference in that horse that made it be exposed but not get sick? And there was a lot of data that was collected. Unfortunately, data takes a long time to be processed and understood and to be put out in the world as something, especially when you're dealing with something so sensitive as EHM, that as a direct conclusion, okay, this is how we can maybe make it better, right? Not with the goal of eradicating it, but we could do better. But then the other part of it is going to be us, the humans, doing the right thing when it comes to taking precautionary measures for protecting horses.
So can we trace back when the neurological strain of EHV became present? How does something like that happen from a virus science point of view? How does that actually, we knew about respiratory, but did respiratory and neurological present at the same time historically?
Well, usually the respiratory might present first, and again, it's a matter of whether or not it's detected.
Right.
So, that's kind of the tricky bit. The neurological presentation has actually always been there.
Really?
Because it's not the most common form that you see HV1, but EHV1 can have a neurological presentation. It's one of the many of 4 ways that it can be presented. It's not the most common way by far, but it is a way that can be presented. Additionally, we often hear words like mutation or neuropathogenic versus non-neuropathogenic, and that's where things get very confusing for people to understand. There's some thought that, the mutated strain of the virus is going to increase the risk of getting the neurological disease. So that's when what we consider genotyping or finding the the genetic material of that virus relevant, because we can tell different strains apart, if you will, right? And we can trace back, are all these strains related to those horses that are getting sick, or is this completely different, which would mean that they're not really related. But again, we know that, and this is what's very difficult to explain even, we called the mutated strain neuropathogenic because there was that thought that it's going to increase the risk of having neurological disease. And then we called the wild type, so the normal one, non-neuropathogenic. But both neuropathogenic and non-neuropathogenic can cause neurological signs in a horse. And that has to do with the virus itself and how the virus behaves.
How does the virus behave?
So the virus will first enter the respiratory tract of the horse and kind of have a replication in the upper respiratory tract. And generally speaking, that's actually going to be the first fever you would see. So we call HV1, as far as a clinical behavior, as having biphasic fevers. You'd have two spurs of fevers in the horse. And that's the first one. That's replication of the virus in the upper respiratory tract, in the cells of the upper respiratory tract. And after that, what it does, it goes into what we call leukocytes, so the white blood cells, and it travels in the white blood cells. It's not traveling freely in the serum blood, it's traveling in the white blood cells. And those white blood cells can get deposited on the lining, if you will, like the single cell lining of blood vessels.
Okay.
And it leads to inflammation, what we call vasculitis. Okay. Subsequently, if that is enough inflammation, you get thrombosis, which is a blood clot. And if you have a blood clot, you lose delivery of blood and oxygen to a certain tissue, leading to essentially ischemia or death from lack of oxygen in that tissue. So that's what happens with the neurological form of the disease. It's still a little bit ill-defined exactly, the time frame and what's being activated or not within the body, but we know it's going to have a preference to these tiny microvessels that are going into the spinal cord of the horse and then causing focal damage. So
and that's why we're seeing, videos of horses that were really hard to watch.
Yeah.
Of horses that were like, literally, it's like they were dying slowly
or not able to get up. Yeah.
It's terrifying.
Because it affects their spinal cord, and it can affect we don't know unless, obviously you have a case that passes and you do a necropsy in the horse, but it can affect multiple segments of the spinal cord. It can affect just one, maybe. We don't know, right? But we know that these horses can have anywhere from more mild neurological signs where they just kind of not coordinated properly, or what we call ataxia, to, the more severe ones where they're down and can't get up.
Yeah.
Viruses generally are self-limiting, but the problem is, the supportive care and a horse succumbing to secondary complications from just being down for so long.
Yeah. It's super scary. You can see why it's such an emotionally charged conversation. So what are some things that we can arm our listeners with as owners or caregivers of horses around the country, across the globe? What are some myths we can bust right now? And what are some things that we can arm them with as we navigate a world in which our horses are experiencing as many pandemics as we are, essentially?
Yeah. I think, in my opinion, to just get that out of the way from the get-go is the fact that the vaccine perspective, right? I've heard people say, well, if it doesn't protect against the neurological form, why do I care to do it anyways? And I would go back to the fact that it's something that's obviously hard to listen to if your horse has gone through it, or if you lost your horse to it. But it's also not just about one horse. It's about all the horses. So you're increasing the chances of maybe the disease not being so prominent on your horse, but also hopefully you're decreasing the amount that your horse would be shedding if it was infected. So regardless of whether or not a vaccine is protective, a vaccine should not be a cushion for you to think that my horse is at no risk for it, but it also shouldn't be seen as, well, there's no point in doing it. And that's just my opinion. Other people can have their opinion. That's perfectly fine. There's a lot of debate also when to use a vaccine during an outbreak, whether or not horses should be vaccinated in the face of an outbreak. And I think as a community of specialists, we've done a lot better job giving direct, more, I wouldn't call it consensus, but more unified way of saying, this is what we would do, regardless of what past publications on outbreaks might tell you. The other thing, to me, the big take home for clients would be knowing how to monitor the horse, right? And the importance of taking temperatures twice a day, and not to be just fixated on a fever. From an educational perspective, we often hear, people saying, well, anything above 101.5 in a horse Fahrenheit would be a fever. Sure, that is true. But the other argument to be made is that if you have a horse that you take in temperatures twice a day, you have a general idea of what range temperature-wise that horse sits.
Yeah.
Right? So let's say it's 99.2 in the morning and 102 in the afternoon.
Yeah.
And that's that horse's temperature. If that horse all of a sudden has like 102 in the morning and 101.2 in the evening, is that technically a fever? No, but that should raise a flag that it is abnormal for that horse.
Yeah.
Right? And just that alone might help us act sooner than later. Because if that temperature keeps rising, that's a good first step to say, well, maybe we should not have people messing with this horse and then messing with other horses. Or maybe we should make an effort to keep this horse's life a little bit more separated at this point, especially at a show.
Yeah.
And get over that mentality of, oh, it's a trailer fever, and take it more seriously. I would even argue that if the horse is normal with a little bit of an elevated temperature, maybe don't jump to just giving Banamine and getting rid of that fever. If the horse is eating, drinking, and everything else is fine, let the horse beat to see if that's truly what's happening in its body. Because if we then just start giving Banamine, they're going to respond to it to some degree, or they're going to respond to it until then that infection has progressed and it's too late, or fire into it. So that's a huge thing for me personally, for people to get in the habit of taking temperatures and knowing what's normal for their horse.
And it's such an accessible thing that we can all do. It's not something that requires, expensive equipment.
And don't share thermometers.
Yeah. Oh, there you go. Okay, everybody. So don't share thermometers.
Well, ideally, but talking to an internist.
Yeah. Okay, fair. I was like, I feel like I might have to.
It can only be so
sterilize. I'm like, I'm going to have to sterilize across my 9 horses. I feel like I'm going to have to sterilize a handful of thermometers, but that's good to know.
Yeah. And then, I think be okay with the consequences too. There might be a time where if your horse is questionable, maybe your horse doesn't need to be ridden.
Yeah.
Maybe doesn't need to be at that show. I think we have to be okay with that as a community, because
gosh, I hope so.
I know it's challenging. I know there's a lot of, again, time, emotion, and investment put to getting a horse to some of these shows to get to that level. But I think we also have to have that self-awareness of taking a step back and saying, okay, is this going to be the best for the horse? Or
what are the consequences if things do not go the way we plan?
Because horses are pretty resilient. You push them, a lot of horses will give you. And I would argue that's not fair to them either. If you think about it, even us, like, we get vaccines, and some of us have bedridden for 2-3 days. We see horses getting vaccines, and 12 hours later people want to ride them, and it's just like,
true.
Is that fair? I mean, are they feeling okay just because they don't have a fever? I mean, we don't know. So again, I think that there's a lot that, unfortunately, these outbreaks bring out as far as awareness. I think people have learned a lot more about biosecurity, and maybe having plans for their own barns as far as biosecurity, how to handle their horses at shows. Like, I've seen people have their own set of gloves and garbage bags outside a stall for their horse. And I think, obviously, that's great. But in the sense, that's kind of similar to, when we were going through our own things of wearing masks or staying in or whatever it may be. And although no situation might ever be perfect, we do the best we can with the knowledge that we have.
Until we know better, and then we
know better.
Yeah. And that's, I think, such an important takeaway, at least for me in this episode, is that this is a constantly changing landscape, not only with the science and the research and the data that we do have, but that I've come to really understand and respect that about our scientific community within the horse world, is that we have the data that we have today, and then we have the data that we have tomorrow, and then we have the data that we have in 10 years' time, and it will be superior because we have better abilities to analyze and process our data. Right. And then we have more compounding data.
Yeah, I mean, 100%. And I think we see that so often in our industry. I mean, medicine, whether it's human medicine or veterinary medicine, it's always changing. And there are things that we do today that we're not going to be doing in 10 years, or we might find out that maybe they're not as good as we thought they were in 10 years, right? We probably have a perfect example with both humans and horses with those GLP-1 medications, and with medications that we have previously tried with horses for insulin resistance and whatnot, where, what we did 5-10 years ago, we might not be doing it today, and we might not be doing it what we do today in 5-10 years down the road. And you got to have maybe a little bit of grace towards your veterinarian that it's not known, it's not flip-flopping, it's just the nature of science. Because if you're not keeping up with it and moving forward, then you're going backwards. Not being involved with it is essentially moving backwards.
Yeah.
And it will change, and we just have to stick with it because, again, every outbreak is going to be unique, and we're going to retroactively be working on them to hopefully make the next one better. And things will have to be interpreted differently. And again, what we try today may not be working tomorrow. Or those things that we laughed about that they did 20 years ago might come back into fashion 20 years from now.
Isn't that the truth?
So,
Yeah.
So you got to be open to those changes.
Yeah, it's not necessarily always better looking forward. Sometimes looking backwards is also important.
Yeah, for sure.
So I wrap up every episode with the same series of rapid fire questions. I'm super excited to hear your answers. So I'm actually going to ask you the horse health version of these rapid fire. Okay. If you could read one book to the horse world, what would it be?
The Alchemist.
Oh my God, that's one of my favorites. I love that. Great book. Great book. Who do you think is the most iconic horse in history?
Secretary.
Oh. What is the most undervalued skill as a horse owner?
Recognition of your own horse.
What do you mean?
Knowing your horse. That's like so much of it is not just what we see in numbers and whatnot, but actually people that know their horse, know how they behave. And at least for me as a veterinarian, it's super helpful.
That information as a vet is...
Yeah, you never undervalue the client's opinion. I mean, we hear all sorts of funny things. It's, oh yeah, this is crazy, and that may be true. But, at the end of the day, they're the people that know their horses. And you should never overlook that.
Who is the greatest horse practitioner or horse health mind in history?
Oh, that's a tough one. I don't think I can say this without being embarrassed. I probably would say people that have had an influence in my life are the most important ones. So, yeah, I think she probably doesn't know this, so I guess it's kind of weird. But when I was going through vet school, I was not originally going to do horses. I grew up with animals. I've always had an affinity towards animals, but my training had always been small animal. And even to this day, they put the stigma on you that if you haven't ridden horses your entire life or been around horses your entire life, you can't be a horse vet, right? And although I had been around horses, I wasn't exactly someone who loved riding horses, or I just liked being around them.
Yeah.
And when I did my internal medicine rotation at Texas A&M with Dr. Michelle Coleman, that's when I decided that I wanted to be like that person. And it wasn't just simply knowledge; it was just more the approach towards like life as in the clinics. And that's what I want to be like. And I was like, that stuck with me, and here I am now.
I love that.
Yeah.
That's a beautiful share.
Yeah.
And then last question. Mares, stallions, or geldings?
Mares, 100%.
Okay, why? Why?
You got to earn your keep with them. I mean, yeah, and I have a soft spot for them because I do with a lot of foals. And admittedly, that's my least favorite part of foals is when, we put so much attention and effort towards the foal that we're not really putting that same attention towards the mare, and it's understandable because there's a lot that goes on to getting a mare bred and whatnot. But yeah, I think that I love mares. I don't know. I don't have anything else to say on that. I just like them.
Team mare.
Team mare for sure. Yeah.
Dr. Bruno Karam, thank you so much.
Yeah, thanks for having us. This is fun.
If the access and insight of this podcast makes you want to go deeper and actually apply these ideas with your own horses, NF Plus is where I've brought together some of the best riders, trainers, horsemen, horsewomen, sports psychologists, and practitioners in the horse world. Inside the NF Plus app, you'll find more than 70 masterclass courses on the challenges so many of us face. Spooky horses, finding a distance, developing a better canter, competing with tension, ours or our horses, building confidence, retraining horses, developing feel, navigating fear and anxiety, or becoming a more thoughtful rider and horse person. Our instructors include Tick Maynard, Will Coleman, Carl Cook, Peter Wild, Dr. Jenny Susser, Archie Cox, Annette Paterakis, Boyd Martin, Laura Graves, Ann Krasinski, Stephen Peters, Josh Nickel, Ian Miller, Martin Fuchs, and so many more. I created NF Plus as a safe, thoughtful place to learn at your own pace, with teachers and riders who have a wealth of knowledge. You can explore more at noellefloydplus.com or find the link to download the app in the show notes.